Hi guys, here is a case study on Parkinson's disease. So the patient, John Doe, he's 70 years old, male, presents with increased muscle stiffness, tremors, and difficulty initiating movements, ongoing for the past year. His wife reports that he's developed a stooped posture and a shuffling gait, and he frequently loses his balance. Additionally, she has noticed that his facial expressions appear blank and less animated. So the patient exhibits resting tremors, muscle rigidity, bradykinesia, which is slowness of movements, and postural instability. His voice has become softer and more monotone, and he has trouble swallowing, leading to frequent drooling. His movements have become progressively slower, and he is having trouble initiating voluntary movements. His balance has deteriorated, increasing the risk of falls. These symptoms are characteristics of Parkinson's disease and align with the expected motor and non-motor manifestations of the disease. The patient has a history of long-term pesticide exposure and has worked as a farmer for over 40 years. He also experienced a mild traumatic brain injury several decades ago. Now, both environmental toxin exposure and head trauma are recognized risk factors of PD. Additionally, his older brother was diagnosed with Parkinson's disease at 75, suggesting a possible genetic predisposition. On physical exam, the patient displays resting tremors in his hands, described as a characteristic pill rolling movement. He also has muscle rigidity with resistant to passive movement, known as cogwheel rigidity. He has bradykinesia, as observed in his slow shuffling gait with reduced arm swing. Also has postural instability, which is leading to difficulty maintaining balance and frequent near falls. He has a masked facial expression with reduced blinking and expressionless face, as well as soft monotone speech with occasional slurring. These findings are hallmarks of Parkinson's disease and result from dopaminergic neuron degeneration in the substantia nigra, leading to an imbalance between excitatory and inhibitory signals in the basal ganglia. As mentioned earlier, the patient's clinical presentation is strongly suggestive of Parkinson's disease. This is because of the presence of the resting tremors, the bradykinesia, the rigidity, and the postural instability, as they are all primary motor symptoms that are required for a clinical diagnosis of Parkinson's. He additionally has masked facial expressions, soft speech, and difficulty swallowing, which additionally support the diagnosis. Now, given his history of pesticide exposure and head trauma, which have been linked to an increased risk of PD, his case aligns also with known environmental risk factors. Parkinson's disease is a neurodegenerative disorder that's characterized by those dopaminergic neuron loss in the substantia nigra and leads to an imbalance of dopamine and acetylcholine in the basal ganglia. This results in excess excitatory stimulation of the motor pathways, causing those hallmark motor dysfunctions. Now, Parkinson's is primarily diagnosed clinically with those signs and symptoms, but additional diagnostic tests may be used to rule out other conditions that present similarly. The tests help to confirm dopaminergic neuron degeneration and differentiate Parkinson's from other neurological disorders. So a dopamine transporter scan is a nuclear imaging test that evaluates the dopamine transporter levels in the brain, which are significantly reduced in Parkinson's due to that dopaminergic neuron loss in the substantia nigra. A positive scan supports a PD diagnosis, while a normal scan suggests an alternative cause of the symptoms. An MRI or a CT does not show or diagnose Parkinson's directly, but they're useful in excluding other brain abnormalities such as a stroke, a brain tumor, hydrocephalus, all which can sometimes mimic those symptoms. A levodopa challenge test can be used to assess the patient's response to dopamine replacement therapy. If these symptoms improve after administering levodopa, it supports the clinical diagnosis. A poor or absent response can suggest an alternative disorder, such as atypical Parkinsonian or a tremor. These tests aid in the diagnostic process, but the definite diagnostic of PD is clinical and based on the presence of the cardinal motor symptoms, the patient's history, and their response to the treatment. The treatment of Parkinson's is symptomatic and primarily aims to improve motor function and quality of life. The cornerstone of treatment is typically dopamine replacement therapy, as the disease is characterized by the degeneration of dopaminergic neurons in the substantia nigra, as mentioned multiple times previously, which leads to dopamine deficiency. So, levodopa therapy. Levodopa is a dopamine precursor and is the most effective medication for managing Parkinson's symptoms. Since dopamine itself can't cross the blood-brain barrier, levodopa is administered and converted into dopamine within the brain. It's commonly combined with carbidopa, which inhibits peripheral breakdown of levodopa and therefore increases its availability in the central nervous system. Dopamine agonists, such as pramipexole and ropinirole, stimulate dopamine receptors, which mimic dopamine's effect and offer an alternative treatment, particularly in these early stages of Parkinson's. Monoamine oxidase inhibitors, such as selegiline and razegiline, prevent the breakdown of dopamine in the brain and prolong levodopa's effects, therefore slowing symptom progression. Anticholinergic medications, such as benzotropine, are used to manage tremors, especially in younger patients. And physical therapy and exercise is important as it can help maintain mobility, flexibility, help with that imbalance and instability, and overall reduce fall risks and overall quality of life. Similarly, speech and occupational therapy are beneficial for addressing those speech and swallowing problems and difficulties with activities of daily living, which commonly develop in later stages. And lastly, for those with advanced Parkinson's who don't respond to medication, deep brain stimulation is a surgical option that involves implanting electrodes into specific brain regions to regulate abnormal movement signals. These treatments provide symptom relief, but there is currently no cure for Parkinson's. There is ongoing research that's focused on disease-modifying therapies, including alpha-synuclein targeting treatments and neuroprotective strategies.